Good evening, everyone. It is my pleasure to welcome you to the 67th edition of the MENASO Education Academy of the Cerebrovascular Grand Round, which is held in collaboration with the European Stroke Organization. It focuses this time on the small strokes, big decisions, acute management, and antiplatelet therapy. The webinar will explore the latest evidence and evolving strategies in the acute management of minor ischemic stroke, with a particular focus on the antiplatelet therapy, clinical decision-making, and optimizing the patient outcomes. This session brings together distinguished experts in the field to discuss the current evidence and to share practical approaches and provide valuable perspectives drawn from their clinical experience. Through meaningful scientific dialogue and the exchange of best practices, the webinar aims to strengthen the clinical decision-making and contribute to improving the quality of stroke care for patients across the region and internationally. It is now my pleasure to introduce and to welcome my co-moderator for today's session, Dr. Irene Scala. Dr. Irene.
Thank you, Professor Abdelalim. I'm pretty excited to be here moderating this session on a cutting-edge topic such as this. Today, we will explore acute management and antiplatelet therapy with Dr. Mariam Demek and Dr. Celia Ratti, who will start with presenting interesting case studies. Then, Dr. Isaac Al-Jabri will discuss antiplatelet use in the MENA region, patterns, pitfalls, and pragmatic choices. Finally, Dr. Christine Tanke will present acute management of minor ischemic stroke. All of these are highly relevant topics, and I'm sure you'll find them both insightful and informative. The question and answer session will follow the last lecture. So now I will now like to hand over to my co-moderator, Professor Abdelalim, for the introduction of the first speaker.
Thank you, Dr. Irene. And it is now my pleasure to introduce my dear colleague and our first speaker, Dr. Mariam Demek, who will present the first case study. Dr. Mariam is the head of the neurology department at Habib Bourguiba University Hospital in Sfax, Tunisia, and she's a distinguished neurologist with expertise in the stroke and cerebrovascular diseases, and she is actively involved in clinical practice, research, and medical education. Dr. Mariam, the floor is yours.
Thank you, Professor Ahmed. Hello, assalamu alaikum, hello everyone. I would like to sincerely thank the MENASO and especially Professor Ahmed Abdelalim for this kind invitation. It is a great honor and pleasure to be part of this educational program. I would also like to express my sincere gratitude to Professor Riyad Guida for his continuous effort in promoting Arab and international neurological collaboration. And finally, I would like to warmly thank my dear friend, Professor Sana Ben Amr, for her help and support in the preparation of this case report. So I will talk about a 74-year-old male with the atrial fibrillation on vitamin K antagonist therapy discounted 1 month prior. He has also coronary artery disease managed medically, and his history, recent history, is since 21 June 2026 at 5:30 minutes. The patient experienced the sudden onset of heaviness involving the left hemibody associated with speech impairment. He presented for medical evaluation 2 hours and a half after symptom onset. The physical examination show mild by ineligible dysarthria and left hemiparesis. NICE score was evaluated at 4. Blood pressure was 170 /90. A capillary blood glucose was at 1.26 gram per liter. No fever, and the ECG showed atrial fibrillation and we make the CT scan. The CT scan was normal and with the aspect score at 10. So no CT evidence of acute ischemic or hemorrhagic stroke. The emergency CT angiography of the supraaortic trunks and the circle of Wallis showed occlusion of the right internal carotid artery, atherosclerotic narrowing of the basilar artery, which appears hypoplasic in its distal segment, and diffuse atherosclerotic change with a narrowed and irregular appearance of the arteries of the circle of Willis, including occlusion of the left posterior cerebral artery. So we are front of sudden onset symptom with since 2 hours and a half with a minor stroke, but disabling stroke. The CT scan was normal with multiple occlusion of large vessel occlusion, the internal carotid artery, the basilar artery, and the left posterior cerebral artery. In this condition, it's a difficult case. What shall we do? Shall we do anti thrombolysis, intravenous thrombolysis, or mechanically disobstruction, or just antiplatelet treatment? So for this minor stroke, minor ischemic stroke, which disabling deficit, with a recent deficit, we must do the intravenous thrombolysis. That was our decision. So the patient had intravenous thrombolysis at 3 hours and a half after symptom onset using tenecteplase. The thrombolytic treatment was well tolerated with no immediate complications, with improvement, favorable neurological improvement with the NIHS score decreasing from 4 to 2. No headache, no evidence of external bleeding. But the contrast brain CT performed 24 hours after thrombolysis showed, you can see, okay, you can see again, hemorrhagic transformation in the cerebella. That was the same finding in the MRI. And we see here that we have no perfusion. But the clinical outcome, it was good. The patient continued clinical improvement, and this hemorrhagic transformation was asymptomatic, and the NIS score at discharge was S2. So, did we do the right decision? And did have as other option the therapeutic options? Thank you.
Thank you, Dr. Mariam. And I'll now hand over to Dr. Irene to present the next speaker. And at the end, we will have a discussion of all cases.
Thank you, Dr. Mariam and Professor Abdelalim. I would now like to welcome Dr. Silja Reti, who will present the second case study. Dr. Silja Reti is a consultant neurologist at the Helsinki University Hospital with expertise in cerebrovascular diseases. She earned a PhD from the University of Helsinki and completed the Master of Advanced Studies in Stroke Medicine program at the University of Bern. Her research interests include posterior circulation stroke, acute stroke treatments, stroke-related visual disorders, and covert brain infarction. Dr. Reti serves on the European Stroke Organization Education Committee. So, Dr. Reti, you're pleased to start with your lecture.
Thank you for the kind invitation. My case will be about a patient with a repeated minor ischemic stroke, and choice of antiplatelet treatment is in this scenario. So the patient was that time a 56-year-old man with elevated blood pressure, but no medication. He had a family history of cardiovascular disease. He was never a smoker and did not use any alcohol. He had no history of migraine. The first episode was on 20th of August 2023, when the patient experienced colorful visual symptoms in the left hemifield, followed by visual field defect and headache, and this lasted for several days. The patient waited for a couple of days before arriving at our emergency department, where his neurological examination was normal, NIHSS score 0, blood pressure was slightly elevated, and he had no fever. Non-contrast CT was unremarkable, but the CTA, which is shown on the right side, revealed a stenosis in the right posterior cerebral artery, but otherwise there were only minor atherosclerotic changes in other arteries. MRI was performed a few days later, and it revealed several small DWY positive lesions within the supply area of the right PCA, and unrelated to the current symptom, also a chronic lacune in the right coronary radiata and white matter hyperintensities, but no micropleats. So the diagnosis for the first episode was minor ischemic stroke due to PCA stenosis. And radiologically, the differential diagnosis included RCVS, vasculitis, and atherosclerosis. So further etiological workup was performed with normal vasculitis panel and CSF, normal thrombophilia panel, and normal cardiac examinations. LDL was 3.0 millimoles per liter, and fasting glucose slightly elevated with 6.8 millimoles per liter. Even though it was already 7 days after the symptom onset, we started dual antiplatelet treatment with aspirin and clopidogrel, which was planned for 3 weeks, followed by single antiplatelet with clopidogrel. Also, atorvastatin was started, as well as calcium channel blocker due to the RCVS suspicion. And follow-up MRI was scheduled at 3 months. However, it was only a few weeks later when the patient experienced the second episode, which was similar to the first one, but this time without headache. This time the patient knew to arrive immediately at our emergency department and arrived within an hour from symptom onset. However, the symptoms had already passed and the NIHSS score was 0. NCCT revealed no new changes, and CTA showed the PCA stenosis unchanged, and other arteries were unremarkable. New MRI and MRA were performed the next day, and they showed new DWY positive lesions within the supply area of the right PCA, but no changes in the PCA stenosis. This time, we also performed vessel wall imaging with contrast agent, and it showed eccentric enhancement of the vessel wall suggestive of atherosclerosis. So the new diagnosis was recurrent minor ischemic stroke due to intracranial large artery atherosclerosis. Because the patient experienced this new symptom while on dual antiplatelet treatment, we performed a genetic testing, and it revealed normal clopidogrel response. So no IVT was performed in the acute phase due to mild and transient symptoms, and we continued with dual antiplatelet treatment, but planned it for 3 months this time due to intracranial atherosclerosis. And atorvastatin was changed to rosuvastatin 40 milligrams with a target LDL below 1.4. However, the patient experienced a new episode after a few weeks, and this time it was again a recurrent visual disturbance. EMS was assessing the patient but did not transport him to the ED. The already planned MRI and MRA were performed in November, and they showed increased enhancement in the PCA stenosis, but no new ischemic lesions. We repeated the etiological workup without any new findings. LDL was still above the targets, and oral glucose tolerance test revealed impaired glucose tolerance. So as the patient had normal response to clopidogrel, we continued with dual antiplatelet treatment, but he had experienced muscle weakness and pain with several different statins, so we changed it to a PCSK9 inhibitor and reduced antihypertensive medication due to hypotension. This time it took a few months until the patient experienced the 4th episode, again recurrent visual disturbance in the left hemifield. He had stopped dual antiplatelet treatment as planned 2 days earlier and changed it to clopidogrel monotherapy. He arrived at our emergency at the same day when the symptoms started, and again the NIHSS score was 0, even though patients still experienced some symptoms. MRI and MRA were unremarkable, and the diagnosis was transient ischemic attack. Because the patient had the symptoms while on monotherapy, we started dual antiplatelet therapy again, at least for 3 weeks. Unfortunately, this wasn't the last episode that the patient experienced. It wasn't more than 11 days that he had new symptoms this time. It was numbness and clumsiness in the left arm and leg, which started in the evening. He arrived at the emergency 1 hour and 20 minutes later and still experienced some subjective clumsiness in the left arm and leg. However, the NIHSS score was 0. New MRI and MRA revealed a new DWY positive lesion in the right internal capsule, but MRA was unremarkable. LDL was now near the target, but glucose was repeatedly above 7.0, suggestive of diabetes. Aspirin response was also normal, and we also performed genetic stroke panel because the patient had repeated symptoms, but it was also normal. So the diagnosis was again recurrent minor ischemic stroke, and this time it wasn't within the supply area of PCA, and the patient also have changes suggestive of small vessel disease, so we think that the patient had 2 etiologies for his strokes. What about treatment? No IVT was performed in the acute phase due to very minor symptoms. We continued again with the dual antiplatelet therapy with aspirin and clopidogrel, this time for 3 months, even though there is no evidence to suggest that the treatment longer than 3 months would be beneficial. We also considered aspirin plus a ticagrelor or aspirin plus low-dose rivaroxaban, but the former we didn't opt for former because there is not much evidence to suggest that ticagrelor would be superior to clopidogrel, and it's not reimbursed in Finland, so it's much more expensive, and did not opt for rivaroxaban according to the COMPASS trial because the patient did not have peripheral atherosclerosis nor coronary artery disease. We suggested to start medication for diabetes, but the patient refused. We followed him for several months, and he had fortunately no new clinical strokes. Neither had he any neither had he new changes in the MRI or MRA. His blood pressure was ideal, his LDL was in the target, and glucose also decreased after lifestyle changes, and the patient claimed to be adherent to medication. Thank you.
Thank you, Dr. Celia, for this interesting case. And now I will be introducing the next speaker. It's Dr. Ishaq Jabri from the Sultanate of Oman. He is a neurologist currently practicing at Suwaig Hospital, and he has completed a stroke fellowship at Queen's University in Canada, where he specialized in acute stroke care and the cerebrovascular diseases. His clinical and academic interests include stroke medicine, neurocritical care, and the evidence-based neurology. Dr. Jabri is committed for advancing stroke care through excellence in clinical practice, medical education, and research, and a strong focus on improvement of patient outcomes and promoting best practices in neurological cases, of neurological care. And now the floor is yours, Dr. Ishaq.
Thanks, Dr. Ahmed, for your kind introduction. Welcome, everybody, and good evening. We are going over the next few slides. We'll talk about antiplatelet use in MENA region. So we'll talk about the patterns, pitfall, and pragmatic choice. We will be focusing on three main lenses, started with the patterns, how antiplatelet being used in our region. Then we'll move up to pharmacogenomic safety axis and data gaps unique to our region. And we'll end up with a pragmatic choice, how to stratified resource decision we should apply it from today. So in terms of why this matter in our region? First of all, we know that the stroke in young adult is rising in our region. And according to the largest cohort study, which is published recently by Dr. Al-Hashmi and her colleague, which is published recently in April 2026, and it includes 4,000 patients from 16 centers among 9 countries. And it showed that the annual incidence was almost reaching 40 per 100,000 person per year. And in Saudi Bowl, the annual rate was almost 29 per 100,000. So if the encouraging news, that's the mortality rate among the region has fallen dramatically in some area among MENA region like Qatar and UAE. But again, the absolute case count are still climbing. And I think this is driven by growth of population, aging, and also rise of metabolic risk factor in younger people. So the progress is uneven. In some Gulf countries, the stroke mortality has sharply declined since 1990, while in other countries, almost there is no change. So this heterogeneity is exactly why a single MENA strategy doesn't work. Here is a quick orientation about antiplatelet. We use it in secondary stroke prevention, started with aspirin, which is a reversible COX-1, and it is a backbone for any monotherapy regime. Then most important, clopidogrel, which is a B2Y2 inhibitor. This is a broad drug that need a hepatic enzyme CYP, C2, C19 activation to work probably. So if this enzyme is impaired, then the drug will not act effectively. So the third drug is ticagrelor. She came and solved this problem. It is a direct reversible B2Y12 inhibitor, which do not need any metabolic activation to work. So it bypass CYP2, C19 problem entirely. And the last drug, I think, dipyridamole, which is BDE inhibitor, and this is used sometimes if the standard agent not suitable. Coming to the patterns, how antiplatelet are actually being used across the region. So again, according to the cohort study, which is published by Dr. Al-Hashmi, again, as I said, it involved more than 4,000 patients from 16 centers among 9 countries. And it showed that the mean age of stroke was almost 37.7 years, with a predominance of male. But again, there is some hidden variation. If you look that the male to female ratio in Qatar was 5.1, while in other countries like Egypt, Iran, Turkey, the ratio was almost 1:1. So the risk profile is generally different between countries, so we cannot generalize. And in terms of risk factor hierarchy from this study, we found that hypertension was leading by 38%, followed by diabetic smoking. And in terms of stroke type, ischemic stroke was the predominant, followed by ICH, and CVST was almost 10%, which is, I think this is driven by association with pregnancy, and also because thrombophilia in our region. In terms of antiplatelet from this study, they found that antiplatelet was the single most common treatment regionally used in almost 56%. But if we look between countries, the antiplatelet use was swinging widely. So, for example, from 58 up to 91 in Iranian patient, which is almost 30. I think this 33-point spread tell us something important. So that's the prescription of antiplatelets not purely driven by the guideline. It's sometimes affected by local cultural resource availability and also practice pattern. In terms of anticoagulation, from this study found is almost 20%, but in some country it raised up to more than 40, like Egypt and Turkey, and this is purely driven by high cardioembolic burden among these population. Another study which is interesting, published in 2025 from which involve a multidisciplinary teaching hospital from UAE. It gave us a real world prescription data among department, not just stroke unit. So from this study, they involve almost more than 100 patients. And they found that the most frequent use was antiplatelet, where the most common by almost 43%. And the top antiplatelet regimen was aspirin clopidogrel, followed by aspirin monotherapy. In terms of anticoagulation, the most common was enoxaparin. The critical insight for us, we found from this study that only 9% of prescription originated from neurology. The majority of prescription was by cardiology and also by general medicine. And more than 92% of patients were on 5 or more drugs, which is an important point here because it means that the antiplatelet choice sits in a complex polypharmacy that may increase the risk of bleeding and interaction. So what's the guidelines said? We know all of us, the AHA guidelines say identify the patient, those who have a minor non-cardioembolic stroke and high-risk TIA with ABCD score more than 4, start dual antiplatelet within 24 hours and extended up to 21 days, then step down to single antiplatelet. The only exception, in case that you found there is a symptomatic intracranial atherosclerosis disease, which may extend the dual antiplatelet for 90 days. Here is that the fourth trial. I'm not going to talk about it. The most important or the latest trial that Inspire, which advised use of dual antiplatelet up to 72 hours in atherosclerotic disease. And I think this trial is important specifically for our region for two reasons. First of all, because prevalence of intra and extracranial atherosclerotic disease is disproportionately prevalent across the region. And the other point is because the late presentation is common in our health system. So most of the patients, they may present or arrive beyond 24-hour window of chance too. So this Inspire tell us that the confirmed atherosclerosis, we can still have actionable window up to 72 hours. Is a dual antiplatelet or how to choose either dual antiplatelet or versus single antiplatelet? You know, the choice is not permanent. It is a phase specific, matching intensity to time window. So dual antiplatelet is an acute phase tool, intense time limited, with a specific window. Start within 24 hours, run it for 21 days, then step down to single antiplatelet. And the only exception for this is to extend the window up to 90 days in those patients who have a symptomatic ICAD. Most important here is just to outweigh the risk, the bleeding risk beyond 21 days. In terms of single antiplatelet is your long-term tool, which you step it at day 21 and maintain it indefinitely. Another important is don't stop it abruptly because of risk of rebound recurrence. And in MENA context, remember, most important adherence, not just the agent selection. And I'll talk later about this. So in terms of pitfall, what's the pharmacogenomic safety and data gaps that makes MENA region different from trial population? First is CYP2, C19 signal is loud and more prevalent. So from almost 20 pool study, including 8 MENA population, they found that the prevalence of loss of functional allele is account for 1.7 in Turkey up to 35 in Jordanian population. And compare that to Western country, which almost the prevalence was 25%, and East Asian, it's almost reaching 60%. So MENA spans the full spectrum, which means a uniform approach to clopidogrel selection is particularly problematic here. Another point here is that's regarding the resistance. We know from chance to that which directly quantified it in confirmed patient with LOF career, the 90 days stroke risk was almost 7.6 compared to tigergerol group, which the risk of 90-day stroke was only 6%. So this absolute difference between both groups, I think, was driven purely by genotype. Carry this across MENA, where loss of functional areas, as I mentioned, it's wide prevalent in some country like Jordan, and the implication become close. Some of patient on clopidogrel are not being adequately protected. So the problem here, we don't know until we test it. Can we, I think to answer this, if we can test the genotype, the answer from Qatar was yes. So there is a study, Qatar QBGX Cares pilot, which include almost 376 patients who underwent point-of-care genotyping in routine cardiovascular care. Demonstrate that a rapid actionable testing can work inside MENA health system. And from this pilot study, they found that almost 22% of patients carry CYP2, C19, LOF allele. And almost 80% of 80% of pharmacogenomic guided prescription were adopted by clinician. And from this trial, the estimated cost saving, it's almost 300 Qatar riyal per patient per year, because you avoid unnecessary ticagrelor use in non-career. Another point in terms of pitfall is the bleeding, which is not a trivial. So we know from a chance to trial that the bleeding risk with ticagrelor, I mean, the moderate and severe bleeding between both group, ticagrelor and clopidogrel, was the same, 0.3. But look at that's the total bleeding. In ticagrelor, it was 5.3 compared to clopidogrel group, which is only 2.5. So the rate was almost double. The practical rule, I think, here is just to simply to give for dual antiplatelet for only for 21 days, then step down to single antiplatelet. Real world data from Lebanese, which has a retrospective cohort, including more than 450 patients, they tracked the bleeding among stroke patients discharged on antiplatelet therapy for secondary prevention. And they found that the regimen dose both shape the bleeding risk in everyday MENA practice. So bleeding is not an abstract trial endpoint. It's a real reason why some patients stop their medication or may present with a complication. Another important point, especially in our Gulf country, I think, the adherence. So Lebanon's stroke, a cohort study involved 100 stroke survivors showed that more than 80% of patients have a good adherence overall, which sound acceptable. But the single most barrier was lack of social security and insurance coverage. Cost concern and side effect were independently predicted adherence. In MENA region, out-of-pocket costs are highly variable. Insurance cover also inconsistent, and the adherence is is almost never tracked alongside prescribing data. Another point regarding register fragmentation, we cannot fix what we cannot measure. There is a review for almost 82 study that show a pharmacogenomic frequency vary not just between MENA countries, but also within the same country. SITS MENA study show that, it tracks the thrombolysis very well, but for the secondary prevention, the prescription was not systemically captured at all. Several countries, including Saudi Arabia, still lack a uniform national stroke registry. I think the last trial that what Dr. Hashmi studied is the first coordinated multi-center report for this space. Last point in terms of pitfall regarding is dual antiplatelet still underused or misused? The answer from Qatar Stroke Registry, which include more than 8,000 patients over 9 years, found that the percent of patients that's the number. So almost 42% of patients who have a high risk TIA and 33.8% of patients who have a minor stroke. Only those persons who have received appropriate dual antiplatelet. On the other hand, more than 34 patients of low risk TIA and 25% who have a non-minor stroke, they receive inappropriately dual antiplatelet, and they face the risk of bleeding without any benefit. What makes this finding particularly striking, there was no improvement over the entire 9 years study period, even after point trial publication and also after the guideline revision. The prescription patterns were identical across 13 consultant neurologists, and time of prescription was made no difference at all. This tells us an important point that the knowledge was not the problem. It's a system design. The guideline was clear and the trial was also clear, but the gap was in implementation. And I think this is what the pragmatic choice section will tell us about this. Coming to the pragmatic choice, what you can take back to your practice from today. I think we know from chance2, which is a single most actionable piece of evidence for our region, in those people with positive LOF career, choose ticagrelor over clopidogrel. And too important was the benefit was clearest among patients with normal kidney function and also have low risk of bleed. Here is the algorithm which I want you guys to take it and apply it if possible. So first of all, choose who is eligible to start them on dual antiplatelet. So any patient with a minor non-cardioembolic stroke with an NIHS score of 3 or high-risk TIA with ABCD score of 4 and above, start dual antiplatelet within 24 hours. You can extend it up to 72 hours based on INSPIRE trial. Next point, which one to choose, either clopidogrel or ticagrelor plus aspirin. I think if you have a genotyping available, then test it. If it LOF is positive, then choose ticagrelor. If it is negative, choose clopidogrel. If in case that the genotyping was not available, the most things is to use clopidogrel to weigh the regional LOF prevalence and also make sure about the bleeding and renal risk. And also, most important, drug cost access before defaulting reflexibility to clopidogrel. In terms of duration, again, limited up to 21 days, then step down to single monotherapy. The only exception, as I said before, is in case the patient has symptomatic intracranial atherosclerotic disease. Then step down to single monotherapist. Make sure about the adherence support in place, insurance, counseling, and follow-up before discharging the patient. I think that's all from my side. Thanks a lot for your listening.
Thank you, Dr. Al-Jabri, for this fantastic lecture. I will now like to introduce Dr. Christine Tanke, who will present the last lecture on acute management of minor ischemic stroke. Dr. Christine Tanke is a vascular neurologist at the University Hospital Heidelberg. Her research focus lies on stroke care implementation in resource-limited regions. As a member of the World Stroke Organization Future Leader Program, she leads the project The Global Reach of Telestroke Care. This project aims to understand global patterns and implementation strategies of telestroke care in order to develop a database for telestroke care standards across diverse settings. So, Dr. Tankol, are you pleased to start with your lecture?
Yes, thank you very much. I just had to unmute myself. Thank you very much to MENASO for the kind invitation. I'm very happy to participate in today's webinar. I hope you can all see my slides and hear my voice. If not, please let me know. I'm particularly excited about today's webinar because it addresses the very important topic of minor ischemic stroke. And that is a disease that we see in nearly 50% of all our stroke patients. Nearly 50% present with minor deficits. So I'm happy to take you through what is a minor stroke, when to give thrombolysis, when and which antiplatelets to give, when is thrombectomy recommended, and what can we do in terms of general medical treatment. So first, we've talked about minor stroke since 45 minutes now, but I would like to take you back to the point, what is actually a minor stroke? So just take a second and imagine you have a patient with a facial palsy presenting with an NIHSS score of 1. Would you say that this is a minor stroke or not? And the next patient, he presents with a severe aphasia with an NIHSS score of 2. Is this a minor stroke or not? And last but not least, a patient with a left-sided hemiparesis presenting with an NIHSS score of 6. Is this a minor stroke? I think most of us will agree from our clinical experience that a facial palsy alone is a minor stroke, whereas a hemiparesis with an NIHSS of 6 is not a minor stroke. But what about the patient who has a severe aphasia? Would this qualify as a minor stroke or not? Typically, we talk about minor stroke if NIHSS score is lower than 3, or other studies report lower than 5. But what I would like to emphasize here is that we should not talk about minor or major stroke, but we need to talk about disabling and non-disabling neurological deficits. And the latest AHA guideline acknowledges that defining deficits that are disabling for one individual patient is challenged by a very subjective consideration, because a deficit that is disabling for one individual may not be for another, right? So, for example, if we have a patient who presents with a mild weakness of his left hand, it's a difference if he is a pianist or not, but both will have an NIHSS score of 1, but for one it might destroy his whole career and his whole life, for the other one not. And that is why the use of NIHSS alone is not sufficient. We need to talk about disability instead of NIHSS if we talk about minor stroke. And of course, the prompt clinical assessment has to be done by us as clinicians, but we need to do the consultation with the patient and the family to decide if this is a disabling or non-disabling deficit. The PRISMS trial that we will talk about later used a very good operational definition for disabling stroke to guide the selection of patients in their trial. So they asked, among patients that present with an NIHSS score of 0 to 5 in our emergency department, if those observed deficits would persist, would they still be able to do basic activities of daily living and return to work or not? If they will be able to do those basic activities, then it's a minor stroke. If this won't be possible anymore with these observed, and they use the bath mnemonic, which I think is very useful for our clinical practice to decide if this is a minor stroke or not. So basic activities of daily living are, for example, bathing, ability to walk independently, toileting, hygiene and hand feeding, and also eating and essential communication. And this is the question that should guide us when we talk about minor stroke and disabling deficits. The AHA guideline really emphasizes that a low NIHSS score does not exclude a disabling stroke, and they give the following examples to highlight this. So a complete hemianopia is considered to be disabling, even though having an NIHSS score of only 2. The same goes for the severe aphasia, a severe neglect, or any weakness or inability to walk. So what I would like you to take home when we talk about minor stroke is always treat the patient and not just the score, and do not deny reperfusion based on the, and you can use the bath score that I showed you before. Why is that so important to talk about disabling versus non-disabling? So we clearly know from all the guidelines that in adult patients with acute ischemic stroke and eligibility for IVT, this improves functional outcomes. But the guideline clearly says this goes for acute ischemic stroke with disabling deficits, regardless of the NIHSS score. And the guideline also says thrombolysis is not recommended for patients with mild non-disabling deficits. And we have some data that brought us to these clear recommendations. So the first trial that investigated this very important question for our clinical routine was the PRISMS trial. It was a Chinese trial that randomized 300 patients to alteplase or oral aspirin to answer the question, does thrombolysis benefit patients with ischemic stroke presenting with minor neurodeficits that are judged not clearly disabling? So does thrombolysis help in non-disabling strokes? And they did not observe a relevant difference between both groups. We have to say that this trial was terminated early due to slow recruitment and financial issues, but even though they could not have a definite conclusion, their data showed that the treatment with alteplase versus aspirin did not increase the likelihood of a favorable functional outcome at 90 days. This trial was followed by the ARAMIS trial, and this trial investigated if dual antiplatelet is non-inferior to thrombolysis in patients with minor non-disabling stroke. They randomized 700 patients to dual antiplatelets with clopidogrel and aspirin versus alteplase. And as we can see here, the group that received dual antiplatelets had a higher chance of receiving an excellent functional outcome at 90 days compared to the alteplase group. And what was even more important is the safety point. So the alteplase group had a higher risk of early neurological deterioration and also a higher risk for severe bleeding. So they clearly concluded that dual antiplatelets are non-inferior to intravenous alteplase in those patients. And the last trial that we have was the TEMPO-2 trial that investigated tenecteplase in acute stroke patients. This trial was mentioned before, in those patients that have an intracranial occlusion. And this trial was stopped early due to futility and did not show any significant effectiveness of tenecteplase compared to the dual antiplatelets. So this is why we say thrombolysis is not recommended for patients with mild non-disabling deficits, and it's our task as clinicians to decide together with the patient and the family if the deficits are disabling or non-disabling. And we already heard a lot, and this was very, very insightful, about the dual antiplatelets and the pitfalls and challenges in the MENA region. And as this is a major topic, I will just briefly guide you through the main findings of the most important trials over the last year. The dual antiplatelet in minor stroke is a very interesting journey that is still ongoing. And it leads to more data and to more individualized treatment approaches over the past years. So as we heard before, everything actually started back in 2013 with the landmark CHANCE trial. This Chinese trial included patients with an NIHSS of 3 or less or high-risk TIA and randomized them to clopidogrel and aspirin for 21 days. And they found that the combination of clopidogrel and aspirin is superior to aspirin alone for reducing the risk of stroke in the first 90 days, and it does not increase the risk of hemorrhage. This was followed by the POINT trial, and the POINT trial was now an international trial that applied clopidogrel and aspirin, but now for 90 days in the same group of patients, kind of. And they also found that the combination of clopidogrel and aspirin has a lower risk of major ischemic events, but they found that there's a higher risk of major hemorrhage than aspirin alone at 90 days. So now we had some uncertainties. We had trials that showed that it has a lower risk of recurrent stroke, but a higher risk of bleeding events. And that's why we needed a pooled analysis. And this pooled analysis of CHANCE and POINT confirmed that there is an efficacy benefit of dual antiplatelets, but this is confined to the first 21 days only. And that is what was mentioned before and what guides our current recommendations, and is also recommended by the ESO guideline, that in patients that have a minor ischemic stroke in the last 24 hours, a 21-day of dual antiplatelet with aspirin and clopidogrel is recommended, and then followed by an antiplatelet monotherapy thereafter. But as we just learned, and as we all know from our clinical practice, we know that clopidogrel is only a prodrug, and it needs an active conversion to its active metabolite in the liver, and this involves many enzymes, and one of them is the CYP2C19. But we know that in the European population, around 5%, in the East Asians, up to 15%, in the MENA region, especially in Jordan, even much more. As I just learned, up to 37% of our patients are poor metabolizers because they have a loss of function of the alleles. So their clopidogrel response is severely impaired. And for those patients, the TALIS trial was very important. This demonstrated that also ticagrelor and aspirin instead of clopidogrel and aspirin are effective and safe if given for 30 days. And this was then followed by the CHANCE trial, a very important trial for our clinical practice. The CHANCE-2 trial was a Chinese trial. We just heard about it. So they compare ticagrelor versus clopidogrel, both with aspirin, in a patient subgroup that have the loss of function. So they are the poor metabolizers. And they saw that in this patient group, ticagrelor is effective and is safe. And that leads to the question, should there be a routine testing of clopidogrel metabolism or not? The genetic testing, and that was already mentioned, the challenges mainly in terms of economic considerations. But this is the database that leads us to these current ongoing discussions. But the journey did not end with CHANCE-2. We already heard about the INSPIRES trial, which is very helpful for our clinical routine because all previous trials included patients presenting within 24 hours, and INSPIRES extended this time window, thankfully for our patients and for us, to 72 hours. So now we have data that show that providing clopidogrel and aspirin is safe if administered between 24 and 72 hours, continued for 21 days, and then followed by a monotherapy with antiplatelets. I told you more data always means more individualized treatment approaches and more complex guidelines and treatment algorithms. And here's the treatment algorithm from the latest AHA guideline. And I'm just going to take you briefly through it. So we have our patient with a minor stroke that is not eligible for revascularization and is presenting within 24 hours. It's a minor stroke, so this patient should be treated with dual antiplatelets, clopidogrel or ticagrelor, according to the CHANCE, POINT, and TALIS trials. If we know that this patient has a loss of function allele of the CYP2C19, then we should treat him definitely with ticagrelor according to the CHANCE-2 trial for 21 days, followed by monotherapy. And nowadays, if our patient does not present within 24 hours, but within 72 hours and has an atherosclerotic disease, then we can still treat him with dual antiplatelets according to the INSPIRES trial. And the journey does definitely not stop here. I think there's no webinar or presentation nowadays without mentioning the oceanic stroke trial, and I'm sure everyone has heard about it. And it's exactly the patient population that we are talking about that will benefit from these findings. So the investigators of oceanic stroke new mechanism, and they had a patient population of over 12,000 patients with non-cardioembolic stroke and a median NIHSS of 3. They treated those patients within 72 hours with either asundexian or placebo, in addition to antiplatelets, mostly with aspirin or clopidogrel. And what they found was just astonishing. They found that asundexian, the factor 11A inhibition, reduces the risk of recurrent stroke by 26%. And on the same hand, and that is even more impressive, it did not increase the risk in major bleeding. So now we have a new medication that, if added to the antiplatelet therapy, will reduce the recurrent stroke risk, but will not increase the risk of major bleeding. And this will definitely change all our guidelines again. And we are very happy about these very positive findings. So now I think we've had enough about antiplatelets, and I will briefly talk you through the other treatment options we have. So what about thrombectomy? If we look at all our LVO patients, it's up to 30% in clinical routine that present with an NIHSS lower than 5. But these patients are largely underrepresented in all our LVO RCTs over the past years. So just to mention this, in Mr. Clean and Extend 1A, it was only 14 patients, not 14%, only 14 patients that were included with an NIHSS lower than 5. But still, this patient group, it's not only up to 30%, but they have a very high chance of experience END and of remaining disabled at 90 days. But still, up to now, we do not have any clear guideline recommendations for EVT in those patients with low NIHSS. So what we have is some observational data. There was an analysis done in 6 centers, also from my colleagues from Heidelberg, and it was a retrospective data analysis, and they compared 220 patients that received best medical treatment with 80 patients that received endovascular treatment, and their data indicated that EVT should be favored in patients with low NIHSS and an LVO. There are 2 RCTs ongoing and still recruiting, and we are very excited for the results. That's the US-based ENDOLO trial and the European MOSTI trial, and they will randomize patients to receiving either EVT or best medical treatment. And hopefully these trials will give us some more precise guidance. What we thankfully have is a consent statement that was done by 40 very famous and recognized international stroke researchers and clinicians. And they provide us a guidance for decision-making in those patients with LVO and mild deficits. What they emphasize is probably not a surprise for us anymore. They clearly say there is not a single universal NIHSS cutoff. This is not appropriate to guide EVT decisions in those patients. But what we should take into account is much more individual factors, such as the degree of disability, again, the anticipated technical difficulties, the collaterals, and also the risk of END. And they emphasize that it needs individualized treatment approaches and patient-centered discussions. So unfortunately, I can't give you a clear answer to should those patients receive EVT or not. It's very individualized. And last but not least, what we should not forget in all those patients is that they benefit from the general medical management. So the main thing is blood pressure, and we know that it's not recommended to lower the blood pressure intensively below 140, but we should treat hypertension in those patients if it's more than 180, with a long-term target of receiving less than 130. We definitely need to target the LDL cholesterol to achieve less than 70 and provide an intensive statin therapy from the beginning. We need to target normothermia, avoid complications such as pneumonia. We should not forget about hyperglycemia and checking for those vascular risk factors, and give a swallowing screen before providing enteral nutrition. And last but not least, also the latest guideline says that all neuroprotective agents are currently not recommended in general to improve the functional outcome. So what I would like you to take home, or better, to take to your clinical routine, is if you have a patient with a minor stroke, define disabling according to the functional impact, not only according to the NIHSS. Thrombolysis is not recommended for patients with mild non-disabling deficits. They have a higher risk that we harm them instead of giving a benefit. But what is definitely recommended is a dual antiplatelet with aspirin and clopidogrel for 21 days, followed by single antiplatelets or ticagrelor if they are a loss of function allele carrier. And unfortunately, until further randomized evidence is available, EVT in low NHSS LVO patients has to be individualized based on clinical and imaging factors. So thank you very much. And I'm sending you best wishes from Heidelberg in Germany. And I'm looking forward to a Q&A session and discussion with you. And please let me know if there are any further questions. Thank you very much for making me part of this great webinar series. Thank you.
Thanks a lot, Dr. Christine. And now we will open the floor for the discussion and questions and answers. I think we'll go back to Dr. Mariam to thank her for this interesting case. And I think the most important take-home message from this case is that not all minor strokes are really minor strokes. It may hide behind it a large vessel occlusion, which may have disastrous impact on the outcome. So I think this is important in the decision making. To be clear that we need to follow these cases maybe more close. They are more prone to complications as what happened in your case. Luckily that the patient is fine after that. And I think we all see this. If you agree with me, Dr. Irene, do you see a lot of cases or many cases with minor strokes which actually hide behind it a large vessel occlusion?
Thank you, Professor Abdelalim. Yes, it is usual, and it is usual also mostly for the posterior circulation stroke. Also because I think that the NIH it is usually used for the anterior circulation stroke is not able to catch all the symptoms of a posterior circulation stroke. So maybe an NIH of 2 or 3 for a posterior circulation stroke may be the index of a more severe stroke in the posterior circulation. And I would like also to ask to Dr. Demek, which kind of secondary prevention therapy did you start to the patient after thrombolysis?
Thank you. So we switch to antivitamin K after 1 month.
Okay.
And one of the questions to Dr. Damek was, did you consider doing MRI for the case before the decision making, or do you think this would waste time? Or you had enough information from the CT based? Yes.
Okay, so time is brain. So if the MRI is available directly, we don't waste time. Yes, we can do the MRI. It will be useful. But if we will lose time, the CT scan is what?
It's far enough. Yes.
Yeah, it's enough. But the Angiou CT is mandatory to see the vessel occlusion.
Yeah, sure.
Okay.
I think the MRI has specific protocols that may be superior to CT, but there are also problems with the MRI that the patient has to be stable, and you may need anesthesia, and some patients with pacemakers may need reprogramming, or some older models cannot do even an MRI. So I think that's why most centers use the CT. Also, the cost of the CT versus the MRI, the ease of use and the time. I think this makes it much better.
Yeah.
Thank you very much.
Maybe the MRI may be used in some cases which are difficult to diagnose. For example, for posterior circulation stroke, usually brain MRI may be more sensitive than CT, but it's not a reason to perform MRI instead of CT to all patients.
Yes. And even in posterior circulation MRIs, I've had some encounters that it may miss. The diffusion is not as sensitive in the posterior circulation as it is for the anterior. I've seen cases that you do an diffusion now, and 6 hours later or 12 hours later, and still the symptoms are persistent. So it's not a fully perfect thing, but we do need it a lot. So,
agree.
yes, for Dr. Celia, now I see that it was a very difficult patient to follow. At the end, he needed the anti-PCSK9 inhibitors. So, did you consider like doing angioplasty or stenting, or was it not feasible? Because I know that the PCA is a lot in a lot of cases it's not feasible to do stenting or angioplasty. So, was that put on the table, or was it not feasible?
We talked about it, but there is really no evidence to suggest that that's a good strategy here. First of all, based on Sampras trial, but also it's technically very difficult, and we have no experience on PCA stenting, so that's why we didn't choose that strategy.
So why do you think this exact patient did have all these recurrent things? What was the problem with him? Which risk factor was not?
That is a very good question, and there was one question about adherence, which is a really important point, and the patient claimed to be adherent to medication. Obviously, one thing that I think played a role was that he had diabetes and hyperglycemia, but he didn't want to use medication for that one, and hyperglycemia might be one thing that kept the vascular status unstable for so long.
Yes, I think also some of the problems are not really, we don't ask about a lot, especially in the Middle East, that the temperatures were high. So the dehydration in patients with intracranial stenosis, I think it could be a problem, especially with older ages. They usually tend not to drink a lot of water because they may have some problems with moving around their house or going to toilets and even going out. So I think we see a lot of triggers to strokes in these cases with dehydration. And immediately when you give some fluids, you see just a major improvement in these cases. So do you follow this in your practice, or you see dehydration causing these problems alone?
Yes, we do, and especially hypotension. This patient also was hypotensive at one point with his medication, and we had to reduce the medication because of that. And I think hypotension might have played a role in at least one of the episodes. So that's a really important point as well.
Yes. Thank you.
I was wondering if did you perform the vessel wall MRI in order to understand the pathogenesis of the stenosis?
Yes, we did. We did it because it was unclear based on CTA and MRA without contrast. So we performed that one, and it was suggestive of atherosclerosis. Obviously, we cannot base the diagnosis only on vessel wall imaging, but we also excluded vasculitis with other etiological workup. And that's why, and because there was no changes in the vascular status, it was clearly not RCVS during the follow-up.
Yeah. And
Thank you.
at that age, would you suspect PFO, or would you look for it if everything is negative, or will not really look into it?
Well, if it would have been an ESUS kind of stroke, yes, we would have looked for it. But in this case, because there was the stenosis and most of the symptoms were compatible with the stenosis, we did not look for PFO.
Okay, thank you very much.
Thank you.
So we'll check if there is any questions for the speakers. Do you have any comment until this moment, Dr. Irene?
Yes. There are a lot of questions about from the floor about the use of dual antiplatelet therapy in patients with intracranial atherosclerosis, in particular for patients who not have a minor stroke. So the question is, when a patient has an intracranial atherosclerosis but not a minor stroke, should that be used?
Yes. Dr. Ishaq, I think may answer this question because he presented a great presentation on antiplatelets and have shown the heterogeneity and the gap that we have in the Middle East. So what's your opinion, Dr. Ishaq?
Yeah, I think I said clearly the only exception to use dual antiplatelet in case the patient has symptomatic ICAD. So in this condition, we use dual antiplatelet for 3 months. no matter how much the NIH score, because here you're looking, that's the etiology. And the etiology here is secondary to symptomatic ICA.
Yes.
Thank you.
And how far do you think that we should use the screening for the antiplatelet resistance and genetic testing? Should we use this in all patients, or especially that in many countries in the Middle East, you know that we don't have all countries at the same economic level. We have high income countries, we have lower middle, higher middle. So in this situation, what do you think? How should we maximize the benefits from that?
Yeah, I don't think that's usually if there is a prevalence of allo of career in this area, you could find that, so you know that's the prevalence in the country. So that time you may think to switch to Gigrilor. Otherwise, the standard regime in our country is like to use aspirin plus clopidogrel. So I don't think that we need to test for, genotyping for clopidogrel, except in some cases where there is like a recurrent stroke in same patient who was on the same regime and he has a good adherence. Again, I'm just focusing on adherence because, as you know, Prof, that's the most common reason here is adherence, and especially in elderly patients who are on multiple medication. So I don't think that's.
Yes, we do see a lot of patients stopping the treatment on their own if they have like episode of epistaxis or minor ecchymosis or something without going back to the doctor. So we do see this a lot. So the same question for our fellows in Europe. So do you do the testing for the antiplatelet genetics and resistance for all of your patients, or what do you do just to compare the practice across continents?
No, we don't do the genetic testing to all patients. We used to prescribe clopidogrel to all patients with aspirin, and in complicated cases, just as Dr. Al-Jabri said, we test the resistance to the clopidogrel in our patients.
Yes, and one of the questions also were about the loading of antiplatelets, because the cardiologists do this with almost all the antiplatelets, even the ticagrelor. So do you have any protocol in your practice doing this loading, or is it like history?
In the hospital in which I worked before, we used to give aspirin 300 milligrams per day and clopidogrel on the first day, and then to give the normal dosage of aspirin with clopidogrel.
Yes.
Yeah.
And Dr. Celia and Dr. Christine, do you do the same also in your practice?
Yes, we do. We always load the patients in the acute phase because we want to have the maximum efficacy within the first couple of days, which are the most where the risk of recurrence is highest. So we do that. And when it comes to the clopidogrel response testing, we have the same strategy as the previous speakers said.
Yes, and I can add to that regarding the loading. It's also recommended in the guidelines that you should do the clopidogrel, aspirin, or ticagrelor. Both, like all of them, should be loaded in the acute stroke.
Yeah, sure. So I think we need to revise that in the Middle East, and for adherence also. The point is that one of the questions also was about if a patient was loaded already, because this is a common mistake that we see in our practice. A patient goes to a hospital that does not have stroke service, but what they do is that they load the patients with antiplatelet and send them to another stroke center. So how far do you think that this would increase the risk of bleeding? So if he takes a regular dose or loading dose, would that do anything with the thrombolysis effect?
It is not a contraindication to thrombolysis to take a single or double antiplatelet therapy.
I mean the loading. Sometimes the loading itself, do you think it can do anything? Of course, we will probably give. We will not stop, but would that do a problem with the thrombolysis or not?
I will not have problem.
Yes. even if yes.
Yeah.
Yes. So I think for the antiplatelet, there is a problem. I think in the practice, especially in the Middle East, that we need to make a homogeneous practice all over countries, all over cities, and we need to do some awareness also. I think it's a problem of awareness by the patients themselves that they stop the treatment on their own. So it's a problem of awareness. If Dr. Ishaq agrees with me, we need to target the media so that please don't stop your medications without going back to your doctor, because we always focus on acute stroke and what to do and the thrombolysis, but we forget about the secondary prevention, and sometimes we do get patients with that.
Yeah, totally agree with you, Prof, about these things, especially in our country. So usually especially the elderly patient, they stop the medication without returning back to their physician.
Yes. So maybe we need a consensus for the region that would not just include the guidelines, would also include awareness, that targeting the media, and I think the cardiologist maybe a bit a step forward in this perspective. So maybe we should follow the same lead. Thank you very much.
I was surprised by the rate of people who are not receiving the optimal medical therapy with dual antiplatelet therapy, and I was wondering which may be the reasons in your region for this.
So again, that's from Qatar Stroke Registry, which was 2022. I mentioned about that surprise that 13 neurologists was not following the guideline and not following the trial. At that time, point trial was published. Anyway, I think that's I'm not sure, to be honest, what's going on, but I think that's now already changed with a lot of stroke physician covering, not the general neurologist who's covering that the decision of, antiplatelet. So I hope that will be changed with the time.
Okay, thank you.
A common practice also is patients exceeding 3 months on dual antiplatelet, either for a cardiac cause, or sometimes the neurologist is afraid to stop one of the antiplatelets because if the patient gets a stroke after that, he will think that this is because of his decision. So do you have this problem also in your practice?
Yeah. We have this problem, and we have also this problem for patients who do not understand how much they have to take the dual antiplatelet therapy. And it is frequent also for patients who are taking dual antiplatelet therapy for cardiology reason, that they come to the hospital with dual antiplatelet therapy that they are taken from years without no reasons. Yeah.
Dr. Christine, thank you very much for this really interesting presentation, because you have highlighted an important thing, that minor is something and disabling is something. And the definition of disabling also is important. Like a patient with a mild aphasia of an NIH of 1 is severely disabled, because this is a part of his communication. So do you think that we should put a profile for these disabling strokes, or should we have it patient by patient, like going to them and asking them if this is really a disabling or not? And maybe we should put things like aphasia, that like for always being disabling and not accepting it as a non-disabling, but maybe like some sensory, some patience, some dysarthria. What do you think about that?
Yes, I think that's a very good point. And from my clinical routine, I find it quite difficult to define if this is disabling or not. And the guidelines recommend that you have to counsel and have to decide on this with the patient and the family. But in this acute stroke situation, everyone is like in a shock. So it's also quite difficult for the patient or the family to decide if this is disabling or not. For the acute stroke patient, I would say everything is disabling, everything is a shock state. And what I really like is the Bath scale, to really imagine if these deficits that I observe in this very moment, if they persist, can the patient go back to bathing, to toileting, to ambulatory walking, to eating alone, and to communicate alone? And I think that is a very, very helpful tool for our clinical practice. And that is something that you can discuss with the patients and the families more easy than asking, is it disabling or not? But the American guideline also highlights that there's a need for further research because we do not have a clear definition on what is disabling or not. But all the trials and also the EVT trials differentiate between disability and non-disability. So that is definitely an area where we need to put much more focus on to facilitate our decision making.
Yes.
Yeah.
Just to give an example, I once had a patient who was a plastic surgeon, and he came presenting only with mild sensory symptoms in one hand. He felt like his hand is numb. He could have full power. And when we talked to him, he said that this is devastating because I'm a plastic surgeon. I work in a very, very sensitive field for the patient under a microscope. I use the smallest threads that you can imagine. So not having the full sensitivity of my hand means that I have fully lost my career. And based on that, we injected him with the thrombolysis, and luckily that he improved. So this is just an example of this situation.
Yeah,
Dr.
I think
Irene,
that the definition of disabling should be individual based because each patient is different. I think that we should consider if the patient will be able to return to do all the things that she used to do before. This may be a good definition, but I don't know. We should surely continue to study this point.
Yeah, sure. Maybe we'll look to the questions if there is further questions that needs to be answered. My question about starting the anticoagulation in patients with AF. In this situation, we'll say that with a minor stroke, if a patient with AF came with a minor stroke, when should we start the anticoagulation? Do you have, Dr. Irene, or any of the speakers, do you have
yeah, there are some
any
trials.
comments?
Yeah, there are some recent trials that have shown that the early initiation of anticoagulation is not a problem, even in not minor strokes, even in moderate strokes with different cutoff points, with different time frames after stroke based on the dimension of the stroke. But all these trials say that in about 1 week, all patients could be anticoagulated.
Sure, yes.
Yeah.
And also sometimes we do see lacunar strokes in patients with AF. It can be misleading that I see this a lot, especially with dehydration. He is compliant on his anticoagulant, and most risk factors are fine. So he gets some, is still smoking maybe, or having dehydration. So you find like a small thalamic infarction or something that doesn't really look like an embolic thing. I think in these cases we can start as early as possible, maybe 3 days or something. So we are not afraid. I think so.
No, surely, surely not afraid.
Yes. Well, there's a lot of question because we have a huge attendance today. It's exceeded 500 attendees. So, but unfortunately, the time will not allow us to answer more. So maybe our secretaries will collect the questions, and we may be able to send to reply back to all our attendees. And I think we are coming to the end of our webinar. So, Dr. Irene, would you like to?
Thank you so much for this wonderful webinar, and to all for being with us today. It has been a truly informative session, and we appreciate your participation and engagement. I'd like to inform everyone that the evaluation form for the webinar will be sent to you within the next week. Once you have completed and submitted the form, you will receive your CME certificate. So, Professor Abdelalim, if you want to hand the webinar.
Well, we thank all the attendees and our speakers for the time and the engagement in our today's webinar. As I said, we have a huge attendance today, exceeding 500. So this commitment to learning and to sharing experiences to strengthen our community and drive the mission of advancing the stroke care across continents, which is an important aim of our joint webinar today, is to exchange experience across continents and learn from each other. And we hope that you have found this session as valuable as you would expect. And we are looking forward to seeing you in upcoming webinars. And of course, I would have to thank the European Stroke Organization for this really great cooperation between our societies. And we are looking forward to the next joint webinar, which we will announce surely soon. So thank you, everyone, and we hope to see you soon. And thanks again for all our distinguished speakers for this interesting webinar today. Thank you and see you.
Thank you.
Have a good night. Have a good night.